I'm Majdi, I'm from OpenBiome, and what I'm going to be walking through in this presentation is the accumulation of the efficacy and safety data that we have built up through our FMT program. And so speaking to the real-world effectiveness and safety of investigational FMT, a decade of data from a national centralized stool bank at OpenBiome. So what I'm going to be walking through is just a bit of a recap of the context that we were working in, as well as the program that we set up to provide treatments to patients, people like Trish around the US experiencing recurrent episodes of C. difficile infection, not responsive to standard therapy. And then I'll walk through the outcomes from a real-world patient cohort that we set up as part of that effort. And then we'll then wrap up with some conclusions and remarks from that data that we're sharing. So I think just to sort of take us back, and apologies, the typo on this slide, pre-2013, access to FMT for C. diff was limited by logistical challenges, despite the public health need. Patients, just I think as Trish so powerfully described, we're trapped in a cycle of antibiotics and relapse. And for those patients who didn't have the options to find a provider near them with FMT, it was essentially inaccessible, with many patients resorting to riskier DIY treatments that were not necessarily screened and were administered even without the supervision of a clinician. And so in 2013, the FDA introduced an enforcement discretion policy that opened a path for patients to access FMT without having to go through applying for an investigational new drug application. And for us at OpenBiome, what that allowed us to do was to set up effectively a blood bank, but for poop, to centralize the screening of donors and the distribution of material in a centralized and standardized way, allowing it to be distributed to clinicians at the point of need. And, we were through that time seeing a number of randomized controlled trials coming up that were demonstrating repeatedly that FMT was sustaining good efficacy for recurrent C. difficile infection. This was done by lower delivery, by upper delivery, capsules, and enema. And across these clinical trials, with controlled experiments, we were seeing that patients were responding well to treatment. And there were also a recognition of the potential risks of FMT as well. Concerns potentially around infection. There were reported cases of infectious transmission, as well as concerns around emerging pathogens, things like SARS-CoV-2. There are also well-recognized risks regarding the procedure itself, so the administration of FMT via colonoscopy, which, things like sedation, the very small risk of perforation, especially in patients with particularly inflamed bowels, and also the risk of aspiration when performed through upper delivery. And these are the sorts of things that we'll walk through in discussion with patients during the consent process. In addition to the known risks, there are also the long-term unknowns as well. And, because this was a relatively new procedure, there hadn't been that accumulation of data over the long term to understand the long-term consequences of it. And so the AGA registry is an example, leading an effort to gather a decade worth of information in terms of follow-up from patients who are receiving FMT, which should enable us to learn more about the long-term effects of the treatment. But, all to say that, the combination of these multiple clinical randomized controlled trials that had repeatedly shown good efficacy for FMT, as well as the known risks, the question really was, do these efficacy rates and the safety profile that we're seeing in these clinical trials hold up when the treatment is used in the broader real-world setting of day-to-day clinical care? And, investigational FMT, I think worth us reminding ourselves as well, its use in treating real life, day-to-day cases of C. difficile that were far too many, and far too many patients who just weren't able to enroll in clinical trials. There was a study performed by Colleen Kelly and colleagues that showed that approximately 75% of referrals to clinical trials during the time that we were providing FMT, patients were ineligible for enrollment into those studies, primarily because of geographic access. So they weren't living near a site that was performing enrolled in a clinical trial. And then also challenges with comorbidities as well, things like inflammatory bowel disease or being immunocompromised that didn't allow them to take part in a study. And so, investigational FMT via enforcement discretion was the only path for many thousands of patients. And so through the years that we were providing FMT, we were able to reach a network of over 1,400 hospitals, providing access to patients, 98% of the US population within a 2-hour drive of a site receiving material from OpenBiome. And at the heart of safety for us at OpenBiome has always been donor screening. It all starts with that. And we published our findings on the complexities of donor screening in the New England Journal of Medicine a few years ago, where we screened 15,000 candidates and whistled that down to 2.5% pass rate, with only 386 donors passing. That rigorous centralized screening process is the cornerstone of our safety program. And so worth bearing in mind, the data that we present here presents a population of donors that perhaps may not be feasible for screening at every single site around the US within a hospital-based program, for example. And some of you may have seen this figure before, but this really summarizes kind of what our safety program is built on. And it's all about that rigorous donor screening, and then importantly, the manufacturing of it in a standardized way in a CGMP manufacturing environment, and then also the traceability, so that for every treatment that we would send out of the door, we would know to which clinician it had gone to, whether or not it had been administered, or whether it was still sitting in the clinician's freezer. And so then if ever we needed to perform any kind of recall or notification to any sites, then we could do that at speed. And in addition to that, we kept a safety aliquot of every single treatment that was administered, so that we could go back and test for any new pathogens or wherever there was a concern for an infectious transmission. And so that's sort of the setting the context, if you like, of how these treatments were manufactured. And they were manufactured to be able to administered through lower delivery, upper delivery, or through capsule formulation. And donor screening wasn't a static process. Our safety program wasn't a static process. Providing material all the way from 2015 to 2023. We had to evolve with the findings of the field as technologies emerged and as new pathogens emerged as well. And so a bit like the way that blood banking evolves through continuous review of the concerns and risks in the outside world, we introduced antimicrobial resistance screening at the outset, actually, in 2015, prior to the reports of the cases of ESBL E. coli that emerged in 2021-22. And in addition to that, we, through our own network, when we identified that the recommended methods for screening E. coli weren't sufficient enough to detect it at especially low levels, we altered our clinical donor screening to move towards PCR-based methods rather than culture-based methods to detect them. And then with SARS-CoV-2, we were able to develop at speed a stool-based screening method for detecting SARS-CoV-2 directly in stool, and able to implement that across all of our donors and across all the material that we had in inventory, and to also share the methods for doing that with the outside world as well, to allow others to perform that screening. And so we set up this real-world cohort where treating physicians submitted de-identified FMT outcomes, with the primary outcomes that they were sharing back to us, reported clinical cure, defined as no CDI recurrence at 8 weeks, through standard of care follow-up at the time post-FMT. We collected quite simple variables, things like treatment ID, hospital, CDI classification, delivery route as well. And these were, when we had all complete consecutively collected forms from these clinicians, they were included in the analysis. In addition to that, all clinicians were trained in submitting safety data to us as well via mandatory SAE reporting using standard FDA definitions. And so each SAE that came through was reviewed by 2 independent non-treating clinicians and assessed for the case and for relatedness as well. And so we gathered these outcomes from our network. We received through the time 9,456 forms, 9,000 cases with complete outcomes data from all across the US, most from California, interestingly, but we received cases from throughout the country on clinical outcomes. The vast majority of these patients were treated by lower delivery. About 30% of our patients were in the fulminant or severe category of disease. So really the sickest, most unwell patients who were, completely, in the inpatient category, hospitalized, often in the ICU with C. diff. The vast majority of those treated by low delivery, and then mild to moderate disease, again, nearly all of these patients being treated via low delivery, with some being offered capsules or upper delivery. And when we say low delivery, the vast majority by colonoscopy, a small number via enema, but the vast majority by colonoscopy. And so, we also saw that patients who were receiving FMT from open biome, they experienced a high number of recurrences before FMT, the majority of them 3 and above. In some extreme cases, we saw patients who had experienced 6 or more episodes of C. diff before getting their first FMT. And you'll see on this histogram, there were some cases where there were 1 or 2 episodes that were treated, and these were patients with fulminant disease who had their initial presentation with the most severe end of the C. diff disease severity. And so the clinicians, for caring for them, opting for FMT in addition to their antibiotic therapy in those cases. So to our first kind of set of results, which were around the clinical cure rates. So among these 9,030 patients, we saw an overall clinical cure rate in this bottom bar of just around 79% effectiveness, which is when we compare that to randomized controlled trials, where we see clinical cure rates of mid-80s, even up to 90% in some cases. It's expected that in a real-world setting, because the patient population is somewhat different, perhaps more sicker, more unwell, with maybe more comorbidities, that cure rate comes down. But to maintain a 79% cure rate was we were really pleased to see that cure rate be sustained amongst this real-world population. And then digging into CDI severity, we also saw that severe and fulminant disease, the cure rate there was 72%, which, considering for these patients, many of them may have been considered for colectomy, which in some studies has up to a 50% mortality within 12 months post-procedure, offers an option for them when they have exhausted all of this that has quite a reasonable clinical cure rate and chance of success. We saw good clinical outcomes with mild and moderate disease as well. And then by delivery route, we unsurprisingly, and as seen in other randomized controlled trials, that lower GI delivery was associated with highest clinical cure rate, followed by capsule delivery, and then upper GI delivery as well, having the lowest cure rate of the 3 different modalities. And so, I mentioned earlier that we had patients who were presenting at various stages of their disease, having had a handful of recurrences all the way through to having 6 or more recurrences. If we follow this trajectory, you can see on the y-axis the number of episodes that the patients had experienced, with the cure rate on the x-axis. You see that for going from 2 episodes to 6, there is a drop-off in clinical cure rates, which has been reported by other groups that have looked in smaller cohorts. And I think this larger cohort of several thousand patients validates that finding, that ideally you want to intervene not too late down the number of occurrences that a patient is experiencing. Now that group of patients that I mentioned earlier who had experienced one episode receiving a treatment, those were predominantly patients, again, with the severe and fulminant disease. So unsurprisingly, a lower clinical cure rate. But I think would be really interesting to consider in the context of primary C. diff, without as many exposures to antibiotics, whether the efficacy of FMT may be as high as we see in patients who've had repeated rounds of antibiotics. I think that's an outstanding question for the field, and one I hope we can look at in sort of more controlled clinical settings. We get asked all the time, is there a donor effect? Do we see any variations? Is there a super donor amongst those 2.5% that that made it through? We didn't see any clinically meaningful differences in donor. Variance in clinical cure rates was just a 0.049, meaning that your difference between a donor that had apparently a higher efficacy versus that has a lower efficacy would have been very, very narrow, perhaps a 2 to 3% meaningful difference in clinical cure rate. So overall, for C. diff, there doesn't appear to be a donor effect. In terms of safety, we saw an overall AE rate of 1.3%. So 1.3% of patients who underwent FMT reported an AE. That's pretty consistent with the findings from other groups, including the AJA registry, as well as some in clinical trials and other cohorts. 113 patients with serious adverse events, and total AE events of 402. Amongst those 113, and the common adverse events were things like diarrhea, fever, abdominal pain, nausea, and vomiting. Hospitalizations associated with those AEs included things like fever, abdominal pain, diarrhea, and as I mentioned earlier, the cases of E. coli that were associated with using a prior system of screening for E. coli based on existing recommendations at the time, which prompted a change in the way that we screen those. And we published that case series in the Clinical Infectious Diseases Journal in 2020. In terms of looking overall, the sort of timing of adverse events as well, these tended to be self-limiting gastrointestinal symptoms. When we looked at things like nausea, vomiting, abdominal pain, these symptoms, as had been reported by other groups, tended to occur mostly very early in the follow-up period, within the first few days, and then eased with time. So I think one thing for clinicians, when we're thinking about follow-up of our patients post FMT, doing that check-in with them at around day 7, day 10. Maybe even earlier, just to see sort of how they're doing post FMT, may allow you to capture any AEs that might be present in the patients post treatment. Overall, we saw no deaths that were related to FMT, and we saw no new safety risks that were identified beyond those that were known for FMT already. So no episodes of any transfer of non-communicable diseases, for example, or any other new risks that were undocumented in the literature. I think one sort of key thing as well that comes from the information that we've been looking at, and which we'll be presenting soon in publication, when we look at immunocompromised patients, that remains, I think, a really critical patient group for us to be mindful of. 44.6% of patients who had an AE reported were immunocompromised, and prospective cohorts have shown that FMT appears to maintain a good clinical cure rate with no infectious AEs in this group. But I think it would be really valuable for us to continue understanding in patients, for example, with cancer or other reasons for immunosuppression, how to optimize FMT administration for that group. Amongst pediatrics as well, that is a population that is unable often to access some of the other treatments that are available to them. We see a good short-term safety and effectiveness, with an 87% clinical cure rate in the NASPGHAN registry that reported by Mary Beth Nicholson and colleagues that was published, and the majority of those treatments using open biomaterial. And I think the third group for us to keep in mind as well are those with C. diff and inflammatory bowel disease. We didn't see any cases either of new onset IBD or worsening of IBD that were definitively related to FMT, but it's really hard to tease apart causality in this population because often their treatment changes. C. diff itself can drive an increase in IBD activity, and also just the stress and change in diet and other factors may contribute to an increase in their risk of having some disease activity post C. diff. But a prospective cohort by Jessica Allegretti in 2022 observed that even not only we think about IBD increase in disease activity, but in that context, 62% of UC patients showed an improvement in their IBD activity. So I think a lot of interesting work still remains to be done to understand how we optimize patients before they get an FMT if they have IBD, and to look at their existing treatments as well. So yeah, in conclusion, we've walked through sort of how our approach to access and quality in the open biome model, where we centralized stool banking and screening of donors, and we're able to implement a rigorous and evolving safety program. In terms of effectiveness, we see that this model was able to provide and monitor the clinical curates out in the field, with, I think, one of the key things, 72% cure rate amongst patients with life-threatening severe and fulminant CDI. And in terms of safety, this large cohort confirms the low SAE rate that has been observed in clinical trials and other registries. However, long-term follow-up is needed. I think some weaknesses that come with any form of real-world data, including this presentation, include things like missing data. We had de-identified information, which meant we couldn't link patients who had multiple rounds of treatment, unfortunately. And these were physician-reported outcomes without the control group that we like to see in clinical trials, so there could have been some reporting bias. And as I mentioned, the short-term follow-up maybe shed light on these short-term AEs, but in the long run, some continued follow-up will be very valuable, as the AGA are doing. So yeah, thank you so much for your attention, and thanks again, Christian and the Peggy Lillis team, for bringing this together and for all the work that you do. So thank you so much.
Well, thank you so much, Majdi. It's always a pleasure to see you and hear